I'd like for everyone to think for a moment about the value of human life. And does one person's life have any more value than another person's? The current fee-for-service healthcare system rations out care based on the patient's ability to pay. I believe this is unethical. It is criminal. 95% of the country is still functioning on this fee-for-service model. I believe everyone should be treated the same. Everyone should have access to primary care regardless of their ability to pay.
Hi, I'm Dr. Faisel Syed. Welcome to another episode of Faisel and Friends. We're here because we believe everyone deserves access to quality primary care, and ChenMed needs physicians to take care of them. Today's topic is change through caring and compassion. My co-host and moderator for the evening, Dr. Dan McCarter. Hi, Dr. Dan.
Hey, Faisel, it's good to be with you.
I am so excited about tonight's topic.
Absolutely. There's no more relevant topic right now. And convincing people how to change and all the talk about vaccine hesitancy, I think this will be a great discussion.
Yes, I can't wait to introduce our friend for the evening, Dr. Bruce Berger. Dr. Berger, thank you so much for joining us tonight.
It's great to be here.
Dr. Berger, when we're talking about something like the COVID vaccine, getting the COVID vaccine, how do you feel when you hear all the public service announcements? Just educate them, just tell them this is why they got to do it. That's how you overcome the hesitancy with the COVID vaccine. How does that make you feel?
It's somewhat frustrating. Now, if you're somebody who is waiting to get the vaccine and you're excited about getting it, those things are wonderful. But if you're somebody who has vaccine hesitancy and you're not so sure you want it, or you definitely know you don't want it, those announcements are really not going to do much of anything for you. As I tell people all the time, when you're dealing with people who are ambivalent or resistant to change, if information alone was enough, no physician or healthcare professional would be overweight or smoke if all we had to do was educate people. I mean, they know, and they're not doing it either. So, it doesn't work. Persuasion, in fact, doesn't work at all. It's the worst strategy to use when people are not ready to do something.
So I'd like to learn about your journey with motivational interviewing. How did you come across it? How have you made changes in people's lives because of it?
Back in the late 1970s or early 80s, I was studying something called the trans-theoretical model of change, and that sounds really kind of highfalutin, but all it is a model that looks at different stages of readiness to change. And one of the things that I realized about the model is it wasn't a good talking model. It didn't really teach you, okay, if you got a patient who's a pre-contemplator, meaning they're not ready to do something, how do you really talk to them? What do you say? And I then found, I really fortuitously came upon motivational interviewing developed by William Miller, a clinical psychologist. And it was developed originally for substance abuse. And I started reading about it, and I was just amazed. By the way, to this day, it is still the most successful intervention for substance abuse in terms of, recidivism or relapse. And so I started thinking, my goodness, if he could do this with somebody who's addicted to a substance, how hard would high blood pressure be? And I wasn't being glib. I just thought it's far less daunting to talk to somebody about that. Well, we started teaching motivational interviewing using his approach, but had a lot of acronyms: READS, ORS, DART. And what we began to find was that the approach was developed for clinical psychologists who understood those acronyms. Healthcare people, creating dissonance did not make a lot of sense to healthcare people.
That's right.
And so not only could they not remember the acronyms, But even if they could remember one of the acronyms was READ, they had a hard time remembering, okay, what was the R for? And then if they could remember what the R was for, then they couldn't figure out, okay, when do I use that again? And so we got rid of all of that stuff. And we went to what is called a sense-making approach based upon a communication professor named Brenda Dervin, who basically said something simple but profound. It says human beings are sense makers. I mean, even as people are listening to us now, they're deciding whether what we say makes sense or not, and they base it on everything they bring to this situation. And so we went to a sense-making approach. We wrote a book. We sent the book to William Miller, the developer of MI, and he actually said it was groundbreaking. He loved it. And so we got rid of all the acronyms. In fact, we call our approach FROMA, free of major acronyms. So anyway, what we really teach people to do is to listen for how is the patient making sense of the illness, its treatment, and their relationship with us. And what we find is when people are ambivalent or resistant to change, which is what MI was developed for, and I'm going to call it MI so I don't have to keep saying motivational interviewing. But we find that when people are ambivalent or resistant to change, their sense making is based upon either incomplete or inaccurate information. And that's vaccine hesitancy is a perfect example, because when people say things like, I don't want to take that vaccine, it'll give me COVID, they're basing their decision on inaccurate information. But it's nonetheless critically important to that patient. Their sense is, I'm not doing this. I don't want to get COVID from some darn vaccine. So we changed the approach, changed how to teach people how to listen, what to listen for. And all of a sudden, bells and whistles started going off in people's heads about, wow, now I get that motivational interviewing is actually about, I'm interviewing the patient to try to understand how their sense making is impacting their motivation for change. And that's an oversimplification, but that's what we've done.
You have to engage them with empathy.
Absolutely.
If they don't,
you have to engage them with empathy, but more than anything else, the relationship drives everything. You know, if you look at me as a patient and you say, I don't want to get the COVID vaccine because I heard it can give you COVID, and the first words out of my mouth are, it can't give you COVID. And I shake my head, and the nonverbals are all saying, listen, stupid, it can't give you COVID. You know, I always tell people, if you can add the word stupid to the end of a sentence and it doesn't change your meaning, you're going down the wrong track, right? So if you, but, and the fact of the matter is, when you're saying to me, I don't want to take this vaccine, it can give me COVID, or I don't want to take this vaccine, you know, it came out way too fast. And so the very first thing I've got to say to you is, you know, you're really worried about the speed with which this vaccine came out, and that makes you really reluctant to want to try it. You don't want to take a risk right now. I have got to let that patient know that I understand their sense making before we have any chance of moving forward. If I don't, why in the world would they listen to me?
That's right. It's just because you have a lab coat on, or you got an MD, DO, or whatever other letter after your name, that alone is not going to make the behavior change happen. Otherwise, we'd have much higher flu vaccination rates as a country. We haven't even crossed 50% with flu vaccination in American adults.
Absolutely. Well, here's an interesting statistic. The rate of non-adherence to medication regimens has not changed for 40 years. In year 2 of a chronic illness, it remains about 50%. 40 years ago, we said the reason was, well, we got 4 times a day regimens. People have a hard time remembering to take it 4 times a day. Well, now we have once a day, once a week, once a month regimens, once every 6 month regimens. And the rate of adherence is still less than 50%. Why? My proposition is we haven't fundamentally changed how we talk to patients. In fact, there's the wrong preposition. We haven't fundamentally changed how we talk to. It should be how we talk with patients.
Yes.